sent you a YouTube link which you can send to your department for the local group people.
Yes, I saw that. Thank you. It's always, you wonder if anyone is going to show up besides the two of us.
No, it's the way we do this meeting is it is just the speaker on Zoom and then everything is on YouTube. So I can see actually almost 50 people on YouTube who are chatting about the presentation.
Oh, all right. So there are people that have joined already.
Yeah, a lot of them, a lot of them. I'm sure within first 5 minutes, the audience crosses more than 100.
Great. It's a very committed group, the Indian surgeons. You have been right all along. This greeting, as opposed to shaking hands, is going to be the future.
So
everyone is going to go like this.
Yeah, you can start that with in your presentation. You can greet the Indian people like this,
or like this.
Yeah, maybe.
So you want to start right on time, right? Are you going to announce or?
So we can start now. Allow me to say a few words about this webcast, and then I'll let you start. So hello everyone. We are live now. Today we have Dr. Marc Levitt with us. He is the Chief of Division of Colorectal and Pelvic Surgery, Reconstructive Surgery, and a Professor of Surgery and Pediatrics at Children's National Hospital from Washington. Dr. Marc, welcome to the platform of IAPS webinar, and thank you for accepting this for doing this presentation. And I would thank you on behalf of Indian Association of Pediatric Surgeons. And we are right now we are streaming on YouTube, and there are a lot of audience waiting for you. So Dr. Marc has today chosen to present on the topic of fecal incontinence and constipation and how you can handle them through various surgical methods. So without any further delay, I would hand it over to Dr. Marc. We can have all the questions posted on the YouTube chat window, and we'll pass on those questions to Dr. Marc at the end of his presentation, which I'm sure he'll be happy to answer them at that time. So thank you again, Dr. Marc. We'll let you start, and please start with your presentation.
Fantastic. I really thank you very much for the invitation. Thrilled to be here with all of you. I will greet you like this with a slight modification. How about that? I wish we were together. I'm sorry we're so far apart. I'm sitting in my office here in Washington, D.C. at the hospital, the Children's National Hospital, and one day we will be together. So what I want to talk to you today, and I really want to hear your questions, a lot of the things I'm going to be speaking about are relatively new ideas that have developed over the last 4 or 5 years due to a very intensive collaboration with the GI motility experts. And there are some definite changes in my own practice that I hope to convey to you. What is the surgeon's role in the management of fecal incontinence and constipation? So we can start with this very important textbook, which is very popular in the United States, and many parents have read this to their children. And I have read this with great meaning because I recognize that there is a second book. The subsequent book to this one is this book. And this is a character that's very well known in the United States, Winnie the Pooh. And Pooh in English, as you probably know, is stool. So this is the challenge. And so many patients, so many children have a problem with this. Independent of anorectal malformation in Hirschsprung's patients, there is an incredibly large population of patients who have severe constipation, and the surgeon is called to help those patients. And in addition, there are patients with spinal disorders who have fecal incontinence, not because they have any problem with their colonic anatomy, but because they have innervation problems related to their spine, and the surgeon has a role in helping those children as well. I think it's important to first
put
start.
It on slideshow? Can you put the screen on slideshow?
Oh, sure. How's that?
Better. Good.
Okay, I'm
going.
gonna. Okay, so what is the essence of continence? Why do we have continence? I think it's really important for the surgeon to understand the three factors that allow you to be continent. One is your sphincters. What happens at the level of the anal sphincter? Well, of course, there's a involuntary sphincter, the smooth muscle of the internal sphincter that remains with high tone and keeps the stool inside, which is then supposed to relax upon rectal distension. And then, so that the stool doesn't come out, we have external sphincters, voluntary controlled sphincters that can squeeze the anal canal and let us find the time to sit in the appropriate position and find a bathroom. That is the sphincter component of continence. Then, of course, we need anal canal sensation. What is happening at the anus? We can detect distension of the rectum. We can detect solid liquid and gas at the level of the anal canal. And then movement of the colon. Is the colonic motility fast or slow? And it's the interplay of these factors that influence proper continence. And as you well know, many of our surgical patients have problems in 1, 2, or even 3 of these areas. This was from a science quiz from, I think, a future colorectal surgeon when the child was asked to name a solid, a liquid, and a gas, and they chose poop, pee, and a fart. Passage of flatus. I love this. I love this answer from a child. Okay, who have problems with continence? Well, these are our 4 patient groups: anorectal malformations, Hirschsprung's disease, spinal problems, and those with functional constipation. And all of these obviously can come to the attention of a surgeon. Now, I think the first step is take a pause and confirm whether or not the anatomy is okay. I cannot emphasize this enough. Gastroenterologists dealing with constipation and incontinence issues almost never stop to ask this question. So, for example, if you have a patient with an anorectal malformation and that patient is fecally incontinent at the age of 5, what if the anus is in the wrong place? What if the anus is not in the center of the sphincter? That's not a patient that can be medically managed. That's a patient that may need a reoperative surgery. What if you have a Hirschsprung's patient who has a lost set of sphincters because of overstretching of the anal canal or a lost dentate line? That is a patient who has an anatomic problem. So I think as a first moment, we need to ask ourselves, is the anatomy okay? And then what is happening in the colon? I like to get a contrast study and see if things are moving fast or things are moving slow. We will get to this in a moment, but the image, is there an anatomic problem here? If the patient is unable to stool, what if they have a stricture at the location of the colostomy closure? That could have an effect on their ability to stool. What if they have a Hirschsprung? What if it's a Hirschsprung's patient who has very little colon because you did a right colon pull through and they actually are hypermodal? That could influence your care. Okay, so what predicts continence? Let's take each of the 4 groups separately. Anorectal malformations. It's very dependent upon what was the original malformation, how was the sacrum, and how was the spine. If those three things are put together, we can come up with what's called a ARM continence index, and we can predict bowel control. So if the patient has a good original malformation and a good surgery, a normal sacrum and a normal spine, that's a patient we can predict should have bowel control. However, if the patient has a high malformation, a problematic sacrum, or a problem in their spine, they will be less likely to have bowel control. In Hirschsprung's patient, what is the status of the anus, of the anal canal? Was the surgery done well? In this photo, not so well. The dentate line and the sphincters are injured. How fast or slow is the colon moving? In spinal problems, what is the effect of, in this case, a myelomeningocele on the anal canal, the sphincters? How severe is the spinal lesion? And in functional constipation, those patients have a normal anal canal. They have normal sphincters and they have a normal spine, yet their colon moves slowly for reasons that we don't really understand well. And here's just a summary slide to so you can think through what are the factors of continence that relates to each of the four types of patients. Well, then the development of the bowel management program, which is essentially a way to control the colon. It's what we all do naturally. It's what patients in these four subgroups need our help to do. Control the colon, empty the colon at a reliable time, and if that can happen, the patient can be clean. So, incontinent patients, we need to decide. Do we use bowel management with an enema program? And are the enemas rectal or antegrade, like via a Malone? Is the patient capable of tolerating laxatives and controlling the flow of stool after the provocation by the laxatives? Do they need softeners? Usually not. They need formed stool. They need formed stool that then gets pushed out by a stimulant laxative. And a very nice trick is to add a stimulant laxative to a water-soluble fiber that provides just enough bulk with the goal that they push out the stool once per day. And then, of course, diet does have an important effect. It can regulate how formed or unformed is the stool. And here's a photograph of a patient who had a little bit too much fiber. All right, hypermotility. That is very tricky and very difficult to deal with. How do we treat such a patient? Let's say the example could be a Hirschsprung's patient with a right colon pull-through, or a patient with an ilioduhamel, or a anorectal malformation patient in whom the colostomy was pulled through because the surgeon lost the rectum due to poor blood supply. Those all have hypermotility. Well, we start with constipating diet. We take good care of the skin to avoid rashes. We provide a fiber, a water-soluble fiber or pectin. The patients may benefit from a small volume enema. Loperamide is very helpful to slow the stool. Be careful, make sure you choose the loperamide that does not have sugar in it, because sugar obviously promotes motility. And then some of the more complicated things like Levsin and Lamodal or clonidine are other mechanisms to slow down the stool, and of course cholestyramine. We don't always use all these latter ones, but we sometimes need to employ that to slow the stool. The goal is to get 1, maybe 2 well-formed stools per day. This is the medical management. Now, I will tell you the bowel management program, and here's some new data, has been fairly successful. It's not perfect. We don't do so well with Hirschsprung's patients who are incontinent, but we've done very well with the other categories. And this is the first study ever produced that showed 1 year out outcomes. Prior to that, the published data is at 1 week. And pretty much any bowel management program can keep a patient clean for 1 week. But can you sustain that a year or years to come? That is the question. And in these situations, you have to choose the right enema and the right cocktail, or the medical regimen, be it for constipation with laxatives or for hypermotility. All right, let's talk about some surgical aspects to fecal incontinence and constipation. The typical patient, and this is a non-ARM and a non-Hirschsprung's patient, has severe constipation, and they have been on multiple laxatives and none have worked, and they have daily cramping and soiling. What do we do? Well, we need to then conclude that maximal medical therapy has failed, and these patients may have failure to thrive. Laxatives may cause intolerable symptoms. The laxatives simply don't work to empty the colon. They have soiling, they have accidents, they have pain. We haven't solved their problem. They've tried bowel management and it didn't work. And amazingly, we've even gone for retrograde enemas or antegrade flushes, and those don't work either. And now we can conclude that the patient has failed maximal medical therapy, and a surgeon really can help such a patient. I like to get a contrast study. The contrast study shows how big or small is the colon. I look at the width. I look at how redundant is the colon. And of course, we want to be sure that we don't have a delayed case of Hirschsprung's disease. Then, and I hope this is available to all of you, anorectal manometry is really helpful. It tells you about the quality of the sphincters. It also tells you whether you have internal sphincter achalasia. Actually, the same sphincter problem that Hirschsprung's patients have can happen in non-Hirschsprung's patients, where the internal sphincter, the smooth muscle, fails to relax upon distension of the rectum. And the treatment for that is Botox. You may have very strong external sphincters, and that child needs to have some behavioral modifications that can be learned in biofeedback to help relax the pelvic floor. Those are very key diagnoses to make. Those are patients that don't need high-dose laxatives. They need a sphincter management. And anorectal manometry is really helpful, and it shows what's supposed to happen to the anal sphincter when you distend the rectum. Normally, there is stool in the rectum, and at that very moment, the internal sphincter is supposed to relax and let the external sphincter take over until you can find a bathroom. However, in internal sphincter achalasia, and actually in Hirschsprung's disease, the internal sphincter, in fact, gets stronger instead of relaxes. And that is a problem that can be fixed with Botox and ultimately learning how to get that internal sphincter to be overcome by the propulsion of stool. Well, I think after you've dealt with the sphincter and the pelvic floor, you need to assess colonic motility. Now, I think the gold standard for this, and I've learned a lot from my GI friends, is colonic motility studies such as this picture, colonic manometry. Now, most centers or many centers don't have access to colonic manometry. I'm not sure if you do, but there are other ways to assess colonic motility. Here are some HAPC diagrams of what a colonic manometry probe will show you. And if you notice, the HAPCs flow through the colon, and the 3 or 4 lines at the bottom that are very flat show that the sigmoid is inert. We can conclude that the sigmoid is inert and is a big part of the problem here with regard to colonic motility. Here are 2 other ways to assess colonic motility, which may be available to you. The SITS marker study that you see on the left, and then the nuclear medicine folks can give you a really nice assessment of colonic manometry. The main questions you want to know is the colonic manometry normal? Is the colonic manometry segmentally abnormal? Or is the colonic manometry diffusely abnormal? Those are the 3 questions you want to ask. And by the way, if you have a nuclear medicine department in your hospital and they don't do colonic studies, I bet they would love to. If you send me an email, I will provide you with the protocol And this is a way that more centers, I think, can start doing colonic manometry. My email, by the way, is mlevitt, M-L-E-V-I-T-T, at childrensnational.org. Feel free to email me. I'd love to hear from you about your cases, your successes, your challenges, and I can give you the nuclear medicine protocol, and you can go enjoy time with your radiologist and see if they're willing to do this study for you. All right, let's talk about a few different key scenarios. Let's say we have a patient with severe constipation, failure to thrive, and diffuse dysmotility. What would you do in that circumstance? Well, I think you have two options here. You can do an ileostomy, give the colon a break. At some point in the future, the colon will potentially improve its motility, or you could try an antegrade option such as a Malone to propulse the stool in a mechanical fashion. How about the next scenario? Severe constipation and an anal sphincter problem. Well, we sort of know what to do here. We have a problem with the sphincter, failure to relax the smooth muscle. The treatment for that is Botox, and the treatment for overactive external sphincter or pelvic floor is biofeedback. And here's one of my favorite Botox pictures, the before and after version of Botox. All right, let's say the anorectal manometry is normal, so the sphincters are normal, but the colonic manometry, or however you choose to assess colonic motility, is also normal. Wow, that's great. Then why is the patient so difficult to empty? Why have they failed medical management? And what is the treatment? Well, the treatment in that case is to provide them with an antegrade option. And these patients do extremely well. Malone or cecostomy. So here is a picture of what a cecostomy could look like with a special button. The patient gets an antegrade enema through that button, or there's a nice picture on the right of a Malone done very cosmetically well in the umbilicus. Antegrade flow of enema is life-changing for these patients. And here are some pictures of the Malone. I like to do a cecal plication, as you see here. By the way, there are also some very nice videos of some of these surgeries. If you go to www.expertsinsurgery.com, that's expertsinsurgery.com, you'll see videos of the Malones, sigmoid resections, etc. All right, so here's some nuance. Obviously, we have a group of surgeons that want to know the details of how to do the surgery. You should know that the mesentery of the appendix is either parallel to the appendix or fenestrated. And when it's parallel, you just wrap the appendix and the mesentery together. And when it's fenestrated, you need to make little windows in the mesentery and put the wrap around the appendix that way. And of course, some patients don't have an appendix. I would strongly advocate, I don't know what's the practice in India, but if you do a LADS procedure in the United States, typically that is accompanied by an appendectomy. However, if it's a patient who might need a Malone or Mitrofanov one day, please leave the appendix alone. For example, let's say you have a patient with a myelomeningocele who has malrotation. Fix the malrotation, leave the appendix alone for the future urologic or colorectal surgeon. And however, if you don't have an appendix, this is a very nice, beautiful operation where you can make a neo-appendix from a flap of colon. You see how I've outlined that there. The flap rolls out and is tubularized and essentially makes a very pretty appendix. Here is the laparoscopic view of what a cecostomy looks like. The cecostomy is created very similar to a gastrostomy. The only difference, of course, is it requires an indwelling tube, and a Malone allows for intermittent catheterization and is a little bit better cosmetically. Now, this is a famous, this is a picture from a famous movie in the United States, Willy Wonka's Chocolate Factory. I don't know if you have seen it. And I sort of joke that when the urologists give me the permission to do them alone, that means they decide that the appendix is not needed for a Mitrophanoff. And if that happens, I'm very happy that I got permission to use the appendix, because you should know that coordinating your care with urology and potentially sharing the appendix is a really nice thing to do in a very collaborative way. We've sort of designed this schema that if the appendix is less than 5 centimeters, then the appendix really needs to become the Malone. It's too short to become a Mitrophanoff, and a Monty Mitrophanoff is created from small bowel. If the appendix is 5 to 7 centimeters, that's a beautiful appendix for the Mitrophanoff, but doesn't leave very much for the Malone. You need to do a neo-Malone out of a flap of right colon or cecum. However, if the appendix is 7 or more centimeters, then you could split the appendix, and the proximal third can become the Malone, and the distal 2/3 can become the Mitrophanoff. And here's what some of that looks like. Here's a very lovely appendix. We have split proximal and distal, and that proximal segment will become the Malone. And there's the Malone with its plication. And the Mitrophanoff obviously moves, the appendix moves off for the Mitrophanoff. I know a lot of you do both urology and colorectal surgery, so the same surgeon could do both. In our hands, we would share that role between colorectal surgery and urology. There's the plication. And the appendix orifice at the umbilicus is done like this. And the circle of the appendix is sutured to the circle of the umbilical skin, or you can make a V to Y anastomosis. And here are some photos of how nicely that looks. Our child life specialists work with the family in advance, and they've designed this doll so the patients can actually learn what it's like to pass a catheter into the umbilicus. Okay, so let's do this scenario. The anorectal manometry is normal, but the colonic manometry or motility assessment is segmentally abnormal in the sigmoid. What do you do? Well, that is a patient, and this is relatively new, that in the past, I would have done a sigmoid resection. Nowadays, I would provide them with a Malone only and watch how they do over the next 4 or so months. 80% or more of those patients respond to antegrade flushes only and never need a sigmoid resection. The ones that don't respond, then you can take out the sigmoid laparoscopically. All right, let's say you tried that and antegrade flushes are not working, and you know that the colonic manometry or motility assessment is abnormal in the sigmoid. Well, the time has come now to do a resection. All right, before you go and do that resection, I would recommend one thing. Make sure the flush is okay. What do you see in this image? This is a child who was not doing well after their flush. But you can see, particularly in the third panel, that all of the flush is going back into the ileum. There is an incompetent ileocecal valve. That's a problem because your flush is not doing what you wanted it to do. Nice treatment for that is have your interventional radiologist help you and provide a longer tube so that the flush can go into the deep right colon, and often that will solve the problem. But if that's not the problem and you think the segment needs to go, then of course you do what I described is a colonic resection, and then you take advantage of the fact that you already have antegrade access with a Malone or a cecostomy. Interestingly, over time, many of these patients learn to control their stool. Their constipation is dramatically improved by the resection, and many of them no longer need the flush. And here's an example of such a colon. And there are certain patients that have very severe dysmotility of the entire colon. And for that group, I have proposed this operation which is essentially what I call an extended resection, and looks something like this, where the right colon is anastomosed to the upper rectum, keeping the Malone access in the right lower quadrant. Again, only for the patient with diffuse colonic dysmotility. Finally, the urologic patient and constipation and antegrade flushes are not working. This is a patient who could potentially benefit from SNS, sacral nerve stimulation. We don't know details about how this works. We do know it helps urologic function. It does seem to be improving colorectal function, and to have a complete conversation, I wanted to add it to this discussion today. So here is a summary slide that you can review the 6 categories of failure of medical management and what the surgeon's role can be. And I'm really thrilled, and thank you for your attention. I hope people were paying attention. I will tell you, I'm at the moment sitting alone in an office, talking to a computer screen, and not 100% convinced that in the last 30 minutes, anyone even listened to me. However, Ravi convinces me that there are some people out there, and I've concluded my formal talk and happy to have your questions.
Thank you, Dr. Marc. You would not believe there were almost 130 people who were listening to you. These were the live viewers, and there would be many more who would be watching these presentations as a recording later.
Very happy to hear that.
Thank you so much. Quite a bunch of questions from the viewers. I'll just read them out to you, and then you can answer them. So the first question is from Dr. Prakash. He's asking that how do you differentiate between Hirschsprung's and the internal sphincter achalasia? And how commonly do you practice the sphincter myotomy or any other modality of intervention in these patients?
So that's a great question. Where was that question coming from?
So it is Dr. Prakash from Chennai. It is down south in India.
And just out of curiosity, is Southern Indian food better than Northern Indian? I don't remember.
Oh, there is a tough competition between that. No one can decide about that.
I'm just kidding. I know that that's a big battle. All right, let me answer your question. Well, it's very important to understand that the internal sphincter problem of internal sphincter achalasia is equivalent to the internal sphincter problem of Hirschsprung's. Of course, the difference between the two is based on the pathology of whether there are ganglion cells or not. If there are no ganglion cells and there are hypertrophic nerves, you're obviously dealing with a Hirschsprung's patient. Our routine is to do an anorectal manometry in the operating room with the patient still awake if they're willing to be cooperative. If they're not that cooperative, we give them a little bit of sedation, but a fully awake patient really gives you a very good anorectal manometry result. If the anorectal manometry is abnormal and there's a failure to relax called an absent rare rectoanal inhibitory reflex, then we put the patient to sleep, we give them the Botox and do a rectal biopsy right then and there as one package. If the patient is a little bit older and cooperative, the anorectal manometry, of course, can be done in the clinic, and then that data should guide whether the patient needs a biopsy or a Botox injection. As far as myotomy is concerned, I basically will not do that procedure. I think that is permanent and has led to fecal incontinence. And I find Botox is much better because it does exactly the same thing, but after 3 months, it wears off. Most of these patients learn how to overcome their sphincter and don't need another Botox. So they certainly don't need a permanent myotomy. And I would be very nervous about doing myotomy because of its potential risk in creating permanent incontinence.
Great. There's another viewer, Dr. Partha Pritam Gupta. He's the president of our association. He's asking how much importance would you give to toilet training and making a 3 or a 4-year-old kid wear a diaper? He thinks that it affects the development of the required reflexes And then too much of use of diaper would actually promote the pathology of constipation in these patients.
You know, that's not only a physiologic, but also a cultural question. But basically, I think that when all the other children in that society are wearing normal underwear, then that's the time to transition the problematic patient to normal underwear. And if they are not capable, because they don't have either the behavioral or the physiologic elements to successfully get into a controlled pattern, then we need to offer them an alternative. And the alternative, as the first step, is bowel management. Bowel management probably in such a case would be with enemas. With enemas through a Foley balloon or Peristeen system. And if they're not tolerant of that, that's also a good option for a Malone for antegrade access. So of course, make the attempts at potty training, but I think it's important to understand what's the likelihood of success. If the patient is a bladder neck fistula with a poor sacrum and spine, they won't successfully potty train at the age of 3. They need a bowel management program to get them clean. If they have severe constipation and their colon is very large, they may not successfully potty train just by giving them lots of laxatives. And maybe behaviorally, they won't take the laxatives. That's a time where you might need to intervene on such a patient.
Yeah, thank you. Can you exit your screen share now so that we can see you on full screen?
Oh, yes, of course. Sorry. Here I am on the beach.
So there's a question about Botox. So whenever you're using Botox for any of these pathologies, do you inject at a particular site or you are injecting circumferentially in that area?
Yeah, so I use 100 units. I mix it in 1 cc of saline. You got to make sure to do it correctly. The vial of Botox is a powder, and the powder is stuck to the bottom of the glass. So I actually put in the 1 cc with the top removed, gently swirl it, don't swirl it too vigorously, and then pull it up into a 1 cc syringe. And then I injected at the dentate line about 2 to 3 millimeters in depth at about 8 positions around the anal canal. Some people use ultrasound to guide them. I have not typically used it because I think I'm putting it in the right place. But I don't have a problem if someone wants to use ultrasound to prove that they're giving it into the internal sphincter. But I actually like to go to affect both sphincters. So I wanted to diffuse out a little bit. Be a little bit careful at the 12 o'clock position. You don't want to give it too deep because then you can actually have urinary retention.
Apart from clinical relief after the Botox injection, would you choose to do a repeat manometry to see the effect and the pressure changes arising out of that injection?
You know, it's a good question. We haven't done that. I'm not exactly sure when the Botox has its maximal effect. It seems like it has effects over the next few days. I don't think it has an effect right away. It definitely has a clinical effect because families say the child is stooling a lot more. And I think the magic really is when it begins to wear off, where it's not fully worn off and the child recognizes that if they push hard or sit in the right position, they can overcome their sphincter. And then they somehow learn, and I don't know exactly what they're learning, but they somehow learn how to overcome the failure to relax of the internal sphincter. If you took a 50-year-old person who had Hirschsprung's surgery when they were 1, and you did an anorectal manometry on them, you likely will find an abnormal sphincter. Yet they have absolutely no clinical sequelae from that. They have learned over time to overcome the internal sphincter's failure to relax at the appropriate time.
Okay. There are multiple comments about the plication around the appendix while you're doing the Malone's procedure. People are saying that is it really necessary to plicate? Because even without plication, according to their experience, it does not leak.
Yes. So about 10 years ago, there were some articles about that. And I said, okay, I will try. And I said, the next 10 Malones I do, I will not plicate. And 5 out of 10 leaked in my own personal hands. and I started to plicate again, and I don't have leakage. Of course, there are some appendices that won't leak, but if you plicate, it definitely won't leak if you plicate correctly. My practice is to plicate.
So, the next query is, in the absence of colonic manometry, will nuclear medicine study with contrast study alone be sufficient in taking the surgical decision? From Dr.
Yes.
Akshay.
Yes, I like to do the contrast study, and I particularly want to look at the post-evacuation film. That gives me a guide. And the colonic motility assessment by nuclear medicine is actually quite good. Many countries use it and don't have colonic manometry. Again, as the surgeon, you only want to know which of the following 3 scenarios are you dealing with. Number 1, is the colonic manometry normal? Number 2, is the colonic manometry segmentally abnormal with the rest of the colon being okay? Or number 3, and luckily this is quite rare, is the entire colon dysmodal? And based on those 3 scenarios, you can formulate a plan. In all of them, we would do an antegrade option first. But I know that if the colonic manometry is normal, I can almost guarantee the Malone will work. If the colonic manometry is abnormal in the sigmoid, I know that 80% of the time Malone only will work. 20% of the time the sigmoid needs to be removed. And in the very severe full dysmotility, it's about 50-50. Many of those patients ultimately come to resection.
Okay. Dr. Prashant is asking, what is your protocol for antegrade and retrograde flushes? Means how you decide about the quantity and the frequency of the flushes for these patients?
Very good. So basically, I look at the contrast study and I make a judgment. Most of the time, we start with 500 cc's of saline. If the child is quite small, I might start with 400 cc's of saline. Into the saline, and by the way, saline, of course, is water, 1,000 cc's of water with 1.5 teaspoons of salt is saline. So anyone can have saline. I have given enemas in various parts of the world, in the developing world, and patients can give themselves a Malone enema. Now, added to the saline, let's say you started with 500 cc's of saline, I like to add glycerin. It's a provocative additive to the flush. I would give 10, 20, or 30 cc's, depending on how strong I want to make the flush. My usual routine is to start with 500 of saline and 20 of glycerin, and that often is the cocktail that works. If you need it stronger, you can add glycerin, or you can actually drop the saline and make it a little bit more concentrated. I like to use x-rays to see if what I chose was the right choice. So if you give a flush and the next day the patient has 4 accidents and the x-ray is clean, well, then your flush was too strong. It provoked the accidents. If the x-ray is full of stool, then your flush was too weak, needs to be made stronger. Even a slightly stronger one, type of enema would be to add to the saline and the glycerin some soap, a gentle soap, like a baby shampoo kind of soap, 10, 20, or 30 cc's. And with a little bit of tinkering, you can often find the cocktail that works to empty that colon.
I think there is an entire set of literature from your group about the bowel management program and all these protocols you're talking about.
Yes, everyone thinks that the bowel management is some magical thing. It's not. It's easy. You need a committed nurse to help you, and you need x-rays to see that what you chose worked. And if it didn't work because the child had accidents, you look at the x-ray and you make a judgment. And feel free to email me scenarios. I have such and such patient. They had this result from this enema, and the x-ray is attached. And I will tell you how I would adjust the flush. And I think we all need to become experts.
Next question is, have you used Chait tube and what is your opinion about it if you have used it?
Yes, the Che tube is a good tube. There's now a new tube made by a company called AMT, which is called a mini ACE. And it finally, after many years of hounding them, they've made it 10 French. And it's a beautiful tube. It looks just like a G tube, and it has a balloon. The nice thing about that is it doesn't leak nearly as much as the Chate, and it doesn't fall out. The problem with the Chate is it floats and it falls out, but it's a permanent access in the tube. Our routine is to do a Malone, but put the tube in up front, and then the track matures over many months. And then we decide with the family whether we want the tube left in all the time, or would they like to try to do intermittent cath, and they cath once or twice a day, once for the flush and a second time to keep the track patent.
Dr. Shripati is asking, is there any merit in left colon placement of Malone?
No. No, don't do it. I'll tell you why. It will clean the left side, but in many patients, the stool will accumulate on the right side and the transverse colon and get constipated there and cause symptoms. I much prefer cleaning the entire colon. I have converted many left-sided ACEs to the right side, and the patient has done much better.
The next question is, what is the incidence of resistant constipation in your practice that require an elaborate workup like manometry and nuclear evacuation studies? So we just know how frequently you see these patients.
Yeah, that's a very good question. I don't have the exact answer, but the way I like to explain it is constipation is incredibly common. It is 1 out of every 10 visits to a regular pediatrician's office is constipation, 1 of 10. And it is the #1 cause of abdominal pain presentations in the emergency room, #1. Very common. I would say that of 1,000 patients that have severe enough constipation to bring that to the attention of a doctor, 900 of them are successfully managed by the pediatrician alone with a little bit of laxatives and an alteration of the diet, which brings us down to 100 out of 1,000. 100 of those patients see a gastroenterologist, a pediatric gastroenterologist, who usually, with some tinkering of the laxative regimen, succeeds in 90 patients. Now we're down to 10 out of 1,000. Those 10 have been referred to me as a surgeon for surgery. And of those 10, 1 needs surgery. 9 just needed a more aggressive laxative regimen, or perhaps some Botox, which I wouldn't really consider surgical, to help their anal sphincter. And the 1 out of now 1,000, again, these numbers are somewhat rough, but needs a surgeon. And the surgeon then can offer the patient either an antegrade option or a sigmoid resection. And our routine is, once you get to that point, we have already pre-screened with an anorectal manometry. That's the time where we do a colonic motility assessment so that we have the data and we make a good judgment about what to do, either a Malone in all cases, and then a subsequent sigmoid resection if the patient does not respond to antegrade flushes. I hope that answers the question.
Yeah, that does. Thank you. I think we'll make this as the last question. This is from Dr. Shiva Kumar. Is there a protocol adopted by your gastroenterology friends to manage functional constipation, and when will they label the patient as resistant?
Very good. Yes, but there's different protocols for different gastroenterologists as far as how much medicine they give and which medicines they give. So we want to be sure that a valiant attempt has been made to medical management. Laxatives have been tried, and laxatives have been tried at a reasonably good dose. And I think there was a slide on this. Whoops. Well, one of the slides, if you go back it was, what were the criteria for failure of medical management? Things like the laxative doesn't empty, even though it's a high dose. The laxative causes severe symptoms. The patient is continuing to soil. The patient simply won't take the laxative. The enemas don't work. I also consider enemas medical treatment. So that is the list. And if we all conclude that that is therefore a failure of medical management, now we need to talk about a more aggressive evaluation and potentially a role for a surgeon.
Great, thank you. I think that was all about those questions which were posted there. And I'm sure there will be many more. Maybe people will contact you through your email. We'll circulate your email amongst our association friends. And
Please.
I think with that, we will end this presentation. So thank you so much for accepting this webinar presentation on a platform of IAPS. It was really great hearing you. And there is a huge round of applause on the online chat window for you.
Happy to do it again. I'd love to do it again.
Yes, maybe we'll pick up another topic from you, maybe somewhere in June, and we'll be very happy to do it again with you, sir.
Perfect. And we hope to all be together in the future, right?
Definitely to have you in one of our meetings whenever we have one, once all this pandemic is over.
Great. Be healthy, everyone. Shall I sign out?
Yeah.